great pleasure of introducing a friend and a colleague and a former fellow student. Peg and I actually did our doctoral programs together, and I got to be familiar with Peg's work during the course of that doctoral program. But Peg DiTulio is a primary care family nurse practitioner in private practice in New Hampshire. She's had a private practice for over 25 years. For the last 15 years, she's followed her passion in evaluating and treating environmentally acquired illnesses. Peg has represented the New Hampshire Nurse Practitioner Association on the New Hampshire Commission to study environmentally triggered chronic illnesses for the past 3 years. And then prior to this role, Peg was also a founding diplomat and treasurer for the International Society for Environmentally Acquired Illness. And Peg will be joining us tonight and speaking on climate change and floods, increasing rates of a lesser known indoor mold-induced inflammatory illness. Peg, thank you so much for joining us tonight, and we're so grateful to have you here.
Thank you, Jen. All right, I guess I should share my screen here. Emily, am I all set to do that? Okay.
Yes, go ahead.
Okay. Okay, I think we're good. Well, I want to thank you, Emily and Jen and the board of directors for inviting me to speak about a topic that I am quite passionate, and it is a great opportunity for me to share this information that likely is not something that many of the participants tonight might have been exposed to, but it is a really important issue in terms of patient care and identifying a particular inflammatory illness that is affecting a lot of people. So I have no relevant financial disclosures. So the objectives for this evening, certainly to connect the climate change with the increasing incidence of more intense water events and more frequent water events, and to then link that those facts with the microbial contamination that occurs when buildings are water damaged, and then to review what we know about traditionally illnesses that traditionally are associated with indoor contamination, with mold and other microbes. And that would be, of course, asthma and allergy, which we're all familiar with. But then I would like to go into a description and a history of this chronic inflammatory response syndrome that was entitled by a physician researcher in the United States. But when you look at the literature on inflammatory effects of indoor microbes, the literature is really diffusely present worldwide. So I'm going to, I selectively chose various articles, research articles, to just illustrate the point that this is not just a domestic issue, that there are researchers around the globe that have already identified this problem, and that, in my opinion, it is ready for prime time now. It is ready for us to integrate into general medical care and the awareness. My goal today is to give you an introduction and an overview, a full discussion of SIRS could be an entire day's conference. So I don't expect anyone to necessarily be familiar with diagnosing or treating it, but simply to understand that it exists and what kinds of patients might you be queued off to in your practices, that this is someone that you need to do a more in-depth environmental history with. So I'll be describing the diagnostic criteria that we use, and also talking a little bit about treatment strategies. But we certainly know that water events are an issue, knowing that this most recent hurricane, Nicole, was the first November hurricane in approximately 40 years. So we know that we're having, you know, a lot more issues. So this was a picture from Hurricane Ian. And the only comment I want to make about this photo is that this house is basically totaled. So once the water recedes, it's really not feasible to remediate a home that got this kind of water damage. And knowing that mold and other microbes start to reproduce within 24 hours of a water intrusion. And if you consider in a humid climate where a lot of these hurricanes and floods are occurring, with the high humidity, you get even exaggerated and intense microbial growth in structures. So what we just looked at was someone's residence, but what we have to also consider is that commercial buildings easily become contaminated when they're flooded. And if you look back in the 1970s after the oil embargo occurred, and the focus in our building strategies was to build very tight buildings to conserve energy. And that was a noble goal. But the problem that ensued was this concept of the sick building syndrome that started to be talked about in the 1970s. And what would happen is you would have a building that didn't breathe, and you had a central heating and cooling system that got contaminated. Depending on where your air handlers are in a building, if that area has had water intrusion and it hasn't been managed correctly, it's easy to have contamination occur. And then you have bad air circulating through an entire building. So back in the 1970s and 80s and 90s, when sick building syndrome was being discussed, when a person with genetic susceptibility to be sickened from this mold would go to their employer and say, this building is making me sick. Since I've been working here, I haven't felt well. I've been tired. I have headaches. I have brain fog. I have pain. And the managers would defend the building by saying, if it were our building, it would be everyone in the building that would be sick. And the important point here is, and I will talk about it more when I go over the criteria that we use, is that genetics matters. And that we know that there are certain haplotypes of HLA genetics where a person is more likely to become constitutionally ill from bad air than their neighbor, and often even other family members. So this really creates a little bit of a dilemma in the person advocating for themselves. So obviously there's a plethora of research worldwide on the increased intensity and frequency of water events and the association with climate change. Here in the United States, I just picked out this one center, UCLA, to demonstrate their work and the predictions for devastating water events could become 3 times more common and 20% more severe by the year 2079. And warming has a profound effect on the severity and frequency of these extreme precipitation events. And we have changing snow and rain patterns that equate to more water. And so the problem is clear. This graph simply illustrates from the extreme one-day precipitation events in the contiguous 48 states, starting from 1910 on the left, going right through 2020. And so it is well illustrated here as to what we're facing. So just a few facts about water damaged buildings. We don't really teach this to people. And as a primary care provider for 28 years, and someone who has studied this particular type of illness, we need to do a better job at helping clinicians understand what kind of questions that need to be asked in terms of environmental exposures. We have a long way to go. Whether you have a washing machine overflow or a bathtub overflow, people need to understand that mold growth begins within 24 to 48 hours of a water intrusion. And if that moist wallboard and other building materials are not removed, and that area completely dried, and antimicrobial is applied, then the chances that some kind of mold growth is going to occur are very high. Mold can actually grow virtually on any substance if the indoor humidity is high enough, and that's estimated to be over 60%. But we know that it proliferates on certain substances. So for mold, wood and paper are actually food. So cardboard, things like this, very easy, especially in a damp basement, for these things to become contaminated, because mold spores are everywhere. They're just waiting to germinate. They're waiting for moisture so they can proliferate. Carpets and porous materials are also known for being quite easily contaminated. So a fun fact that many people may not realize, and this is World Health Organization criteria for a water damaged building, is that a musty smell is evidence enough that mold is present. And so not every mold will put out a VOC that will be a musty smell. So you can't rule out water damage by the lack of a musty smell, but if it's present, then there's mold somewhere. There are many compounds, both toxogens and inflammagens, that are present in the air of water damaged buildings. And this was documented in many important reports. The US Government Accounting Office report of as far back as 2008, certainly the World Health Organization report of 2009. That World Health Organization document is about 400 pages. It's enormous, talking about mold in structures. So what we're talking about when we're saying many compounds, we're talking about mold or fungus, we're talking about mycotoxins, we talk about bacteria and endotoxins. And all of these things are gases that you can't see and are in the air that people breathe. So I don't have to tell you what this is. It's a worst case scenario of a basement that's been water damaged, and probably because of the color of this would be certainly look like Stachybotrys, which most people, consumers can say that bad black mold, but what they don't understand is there are molds of many other colors that produce spores that are just as toxigenic as Stachybotrys. So, but it's important to know that this is an extreme picture. Even a small part of this contamination, even a $0.50 size growth, can be enough to put spores in the air that could ultimately impact the health status of someone in the first floor or other floors of the building if there is a central heating and cooling system. So what we know is physics teaches us that there is a stacking effect where warm air rises. So the warm air in the home tries to escape through the upper floors and the attic space. And as the warm air rises, it pulls up the air from the lower places. So even mold in a basement can impact someone in the first floor because the spores will stack up to the next level. A well-known, nationally well-known and published indoor environmental professional that is in the group that I work with, John Banta, he helps us to understand visually what this means by saying, an opening the size of a human hair is like a freeway for spores. And so if you think about it that way, you can understand all the nooks and crannies and places and the cellar door that doesn't come down, that the air moves up in that stacking effect. So I just included this unfortunate woman to talk about the toll that water damage takes on many different levels. The emotional toll that she will suffer from having to get rid of sentimental items and things that were important to her that now will be contaminated. The financial toll, if she is insured, there still is not full coverage, mostly for the things that you lose. And if you're not insured at all, the risk is that there's going to be a not an adequate remediation of the water damage. And then you see the futuristic problem. And the futuristic problem is if it's not remediated fully and appropriately, then this woman could be one of the people that I'm going to describe who ends up with an innate immune system that is on fire. And it's important to also appreciate that this neighborhood that was hit by a hurricane and certainly had flooding, the flooding is regressed now. But when you look at the structure of the houses, they've incurred a lot of damage. And so if you have a roof that is needs repairing and it's raining, you're going to run into even more problems. And you can see the extent of the potential here for people to be exposed to water damaged buildings. So we mentioned that the well-known effects of being in a building that is water damaged and breathing the air. We know that if you're allergic to mold, that's quite clear. If you have asthma, that also is well known, and worsening COPD certainly. But the situation I'm going to describe for you this evening is a chronic innate immune system activation that causes a multitude of symptoms constitutionally, and I've categorized them here for the purposes of simplicity into three major categories. And you'll see that throughout some of the slides, there's a theme with these three major categories, and that is chronic fatigue, chronic pain, and cognitive impairment, or as the consumer or layperson likes to call it, brain fog. So anyone in clinical practice has seen these patients. You might not you didn't know it at the time maybe, but maybe you can recall. These are the patients that challenge a clinician incredibly, because they will come into your office and they will have a laundry list of complaints and concerns. And it's really hard to even know where to start with a chief complaint or a differential diagnosis, because the complaints are so diffuse. And they often are appearing anxious and depressed. And one of the challenges with uninformed clinicians is that our default for this patient is to say, well, they must be depressed to have all these things going on, and to reach for a prescription for fluoxetine or some other antidepressant or anxiety medication. So for this patient, that is not the right approach, because that is not going to solve the problem. Are they anxious and depressed? Almost always. But their secondary problems to a primary innate immune system that is overactive and basically a brain on fire. So they're, and they also are quite anxious and depressed from being to many providers of care with all of their complaints and feeling dismissed by being handed a prescription for an antidepressant, because in their gut, they know that there's something more to their illness and that is not simply depression or anxiety. So they are very, very challenging patients for clinicians. It doesn't matter where you are. You might, you could be a school nurse and you could have, the child coming in with all kinds of complaints and not really understanding what was the root cause for all this. Any area of medicine or healthcare, you certainly can see these people. Social workers clearly see them, and it's a little difficult to sift it all out. So where did this kind of the story began with a sick building syndrome concept in the late 1900s. So here in 2006, we had the first real opportunity to have documentation for what actually happens with that sick building syndrome and what actually helped reverse the symptoms after the person came out of that sick building. So Dr. Shoemaker, I'll talk a little bit more about further into the presentation, but he is was a practicing family physician and also a physician scientist who was responsible for doing a lot of the research on the illness called SIRS, connected to a lot of different toxogens. Dennis House was an evaluator with the EPA. And so they collaborate on this study. The hypothesis was chronic exposure to the indoor air of water damaged buildings is associated with sick building syndrome. And basically they used different parameters to evaluate patients over the course of 5 different appointments. And they looked at visual contrast sensitivity testing, which is a wonderful tool for indirectly measuring brain inflammation. It was developed by neuro-ophthalmologists in the UK in the earlier 1900s. It's non-invasive, and it is it's a tool that we use frequently in looking at these folks. But House and Shoemaker used this back in 2006 in this study, looking at cytokines, particularly MMP9 was the cytokine looked at here, but we now have others that we have added to that constellation. Looked at pulmonary function studies, because the interesting thing is when people have SIRS, they might appear to have an obstructive asthma-like condition, but when you test their pulmonary function studies, they actually have a restrictive pattern. And I'm not talking about a large barrel-chested male who you would expect might just naturally have a restrictive pattern. I'm talking about just a petite female who has become sick in this building and will have a restrictive pattern on pulmonary function studies. And also looked at regulatory hormones, which we'll talk a little bit more about later. But when the brain is on fire with cytokines, you have reduced production of regulatory hormones, which then creates a cascade of effects globally. So in this study, they saw people at 5 different intervals, and the treatment was introduced at the 4th visit, and cholestyramine, a bile acid sequestrant, which has been used for many different toxic exposures over time, was used in this case. And in fact, the people given the cholestyramine showed improvement, statistically significant improvement over the placebo group. So this was kind of the documentation of the illness that was associated with sick building syndrome. So then we had a group of treating physicians get together for the Policyholders of America in 2010 and come up with a consensus statement. This was 161 pages. It certainly helped to define the illness even further. It reinforced that in water damaged buildings, there's a multitude of microbes that create toxic effects and inflammation. And this was, again, consistent with the USGAO report and the WHO report from 2009. So this was a study, so we'll go across the pond, we'll go to Poland here. So this was a study done in Poland in 2011. And the goal of the study was to assess the potential impact of early childhood exposure to indoor mold. Now, in this study, the mold was visible to the eye. This wasn't hidden mold, it wasn't suspected mold. These were homes that had obvious mold contamination. And basically they took 277 healthy full-term infants who were born to healthy mothers. And they did adjust for many confounders in the study as well. But at age 6, they administered the Wechsler Intelligence Scale for children. And what they found was there was a statistically significant lower IQ in those children who had been exposed for more than 2 years compared to the unexposed reference group. So here again, when you talk about the adverse impact to the neurologic system in general to someone who has this innate immune system activation, some of the most challenging cases that we see are children who are born into and brought home to a water damaged home. So we have to, again, my consistent message throughout for anyone working with the public in this regard, in healthcare, is to ask the questions and do a little more delving into these areas. So back to the United States, just to identify that it wasn't just Shoemaker and his group that were looking at this issue. This is Dr. Jeanette Hope, again, a physician researcher out in California, and this is 2013. She wrote this 20-page lit review talking about the microbial soup that made up water damaged buildings and the injury to the nervous system and to other systems from exposure. And then back to Finland, 2020. This was a study that looked at a cohort of 90 midwives and nurses that were known to be working in, Europe and Australia. They call it moist environments. And what they were interested in, the researchers, was to identify extrapulmonary symptoms. So they knew that people could get worsening of their asthma or their allergies. They were looking for other issues, particularly, nervous system effects and chemical sensitivity. Chemical sensitivity is a concept that we really haven't defined well in the United States. There are many people who are chemically sensitive, and I will just say that if you come across someone who is chemically sensitive, they would be someone you would want to inquire about environment as well, because we see increased chemical sensitivity in this population, pretty widespread. But back to the Finnish study. So basically, they compared the cohort of 90 midwives and nurses who were exposed to the dampness microbiota to 45 controls that were unexposed. And what they found, and here's the theme again, statistically significant findings of what? Chronic pain, chronic fatigue, and brain fog. These are the three major kind of categories that we see identified in these folks. So I included this slide because it illustrates the potential for numerous functional, what we've considered functional disorders, that maybe we need to be relooking at them and asking more questions about environment. So this was Albrecht et al. This was a large group of researchers. It was a multi-site study, 2019, Boston at Mass General and Stockholm, Sweden. And basically, there was a patient grouping of 31 patients diagnosed with fibromyalgia. And what do fibromyalgia patients have? Chronic pain, chronic fatigue, and brain fog. When you look at the literature, those are the things they complain about. There were 27 healthy controls. And what they did this very specialized PET imaging using a tracer that is picked up by the microglia and the astrocytes really well. And the findings of this study was that compared to the healthy controls, the fibromyalgia patients demonstrated widespread cortical elevations and basically glial activation, which would then categorize that as more of an inflammatory condition versus a functional. So this work clearly has to be duplicated, more work has to be done, but it certainly raises the question of whether or not people with fibromyalgia have actually an inflammatory condition versus a functional one. So I just want to mention Dr. Shoemaker's work previous to even looking at water damaged buildings, and to just make a statement that physician scientists in the community can do much to advance science. And the international group that works with Dr. Shoemaker appreciate his genius in this regard. But basically, as a practicing family physician on the shores of Maryland back in 1998, Dr. Shoemaker came across this situation where the patients were sick from eating fish. There had been a large fish kill, and it turned out that Pfiesteria blooms were creating toxins. The people were eating the contaminated fish, and the people were getting sick. But the interesting thing about it, and here is where genetics matters, it wasn't everyone that didn't get better on their own. It was about 25% of the patients that had persistent multi-symptom illness. And when they were given cholestyramine, a bile acid sequestrant, their symptoms reversed. His work went on to look at post-Lyme disease syndrome, the people that have persistent symptoms after what would be considered reasonable and adequate treatment for Lyme disease. And in many of those cases, it turned out that these people just could not clear the dye off from what they had killed with their treatments. And cholestyramine was able to reverse their symptoms as well. In 2015, looking at ciguatera and ciguatoxins, I've never seen a case of ciguatera toxin illness. There aren't a lot of reef fish species up here, but for people who live in areas where they exist, they certainly have seen this illness, and it is really acutely disabling. And so what Dr. Shoemaker was able to document was that these patients would reverse their symptoms, again, with cholestyramine, and Dr. Shoemaker and others had started to do transcriptomic work, looking at messenger RNA and gene activation. And in 2015, we're actually able to document that the gene activation associated with this illness as well, which was even more advancement. So for the 20 years, as all this work was going on, the investigation into sick building syndrome and water damaged buildings and all of this was going on. The group was expanding. There were more people doing research. And in 2018, a subgroup of the larger group got together to put together this document, which is a diagnostic process for SIRS. And it was a consensus statement of the group that treats. So what are the fundamentals of SIRS? Well, I already mentioned that the patients generally are have multiple complaints in multiple systems. And this is usually associated with cytokine activation and reduced production of regulatory hormones. So we do need a biotoxin trigger. I've gone over a few examples of biotoxin triggers that were already identified and studied. Certainly things like cyanotoxin is an area where there is research currently being done about neurologic impact from cyanotoxin. And so more work in that area needs to be done. But it is interesting that even the research on the PFAS chemicals, the experts that I talked to are confirming that cholestyramine is being studied for potential positive impact on removing PFAS chemicals from people. So that would be an expansion even into another area where these are artificial. So the susceptibility is as I said, in a heterogeneous community, it's about 25% of the population, it's estimated. If you go to Northern Europe, the Northern Europeans are very sensitive people to environments, and they have actually published a lot of literature about this. So they probably are about 40% if you're talking about the pure Northern European. So your English, your Irish, and your Scandinavian countries tend to be more apt to be susceptible. But it is a defective antigen presentation that is the problem. So one of the issues that arises for these folks when they go into an uninformed clinician and they're reporting all of these complaints, the clinician will say, well, it sounds to me like you have some inflammation, and they will check the markers that we historically are taught to check. And they'll check a sedimentation rate, and they'll check a CRP, and those will be normal because those pathways are not activated in this condition. So you have a clinician that looks at the typical markers for inflammation, a patient with all of these complaints, and the clinician says, well, you don't have inflammation, not realizing that there is a whole spectrum of inflammatory markers that we don't look at routinely. And so that's kind of where the disconnect occurs often, and the patient is then just thought to be depressed. And if I just give this patient some Prozac, they will feel better. So what kind of tools do we use? We look at inflammatory cytokines. So complement 3A and 4A, these are split complements. 3A is typically up if there's bacterial involvement of some sort. So we always use that as a control for not missing some hidden tick-borne illness, which sometimes will raise the C3A. Human transgrowth factor beta-1, TGF beta-1, matrix mineraloproteinase 9, the MMP9 that I mentioned. So we check these things routinely, and in these folks who are sickened from water damaged buildings, you will see elevations of these markers. So they really are on fire when they're elevated. They do have inflammation. It's just not along the pathway that we're used to looking at. So what happens with the brain on fire? Now you have regulatory hormone dysregulation. Your hypothalamus is a factory who can't make the hormones that it should be making. So we see reductions in alpha melanocyte stimulating hormone, which has an effect on endorphin production and melatonin production and ACTH and cortisol regulation. So you can see what happens here when there's a fire in the brain, and now the hormone production goes down, and now the person dysregulates terribly. Their antidiuretic hormone, now called copeptin by Quest, so they run lower antidiuretic hormone. So this is the person that is thirsty all the time, thinks they have diabetes. They go, I must have diabetes, I'm thirsty all the time, and I'm in the bathroom all the time. Well, their blood sugar's fine, but their antidiuretic hormone probably isn't. It's probably very low. And so, that creates its own symptoms. Now, vasoactive intestinal polypeptide, again, this is a regulatory peptide from the hypothalamus, which we've been testing for years. Interestingly enough, had great success with COVID patients. Starting in Israel, the Israelis were using VIP in their ventilated patients and in their patients who were near to be ventilated. And because this hormone has so much to do with oxygen delivery, and when you have reductions in VIP, you actually have acquired pulmonary hypertension in some cases. So in those cases where we're looking at cardiopulmonary stress testing, these patients test out like heart failure patients often when their VIP is way too low. So we lose regulatory control. And then there are other regulators. So we look at vascular endothelial growth factor, VEGF, which tends to decline in production in these folks who are ill from water damaged buildings. And when you have low VEGF, you have relative hypoxia because this regulator has to do with the creation of new microcapillaries and the dilation of existing ones. So if you have low VEGF, you can't really dilate your microcapillaries to the degree that you want to and need to. We see reductions in certain Treg cells, CD4, CD25, and basically when TGF-beta1 goes too high, it has a suppressive effect on these important Treg cells that help us to ward off autoimmunity that we might be predisposed to. So we do also check for more things than this, but we check for certain autoimmune conditions as well. And then testosterone and DHEA often are low because MSH is low, and that is a precursor hormone. I mentioned the visual contrast sensitivity testing. That is a tool that we use in the office. It also can be done online. We use a specialized brain imaging. It's a non-contrast brain MRI done at a center that does volumetric measurements. So this is three-dimensional measurements of 36 brain structures. This was FDA approved initially for following Alzheimer's and traumatic brain injury. Those were the two big indications. And all Dr. Shoemaker and the group did was, Dr. Shoemaker appreciated that there was apt to be changes in volume and swelling with exposure. And in fact, yes, you see above the 95th percentile in certain structures when people are exposed. And then you see atrophy develop, which is defined as below the 5th percentile. And so it gives us a monitoring imaging study where we can see improvement as we work with people to eliminate their exposure and to really support neurogenesis, which we know that we can do today. And then the most recent work has been in the gene, what's called the GENIE, and that's the gene activation inflammation explained. This is the messenger RNA gene activation. It's basically around 200 genes that were selected that have to do with environmental illness, and looking at upregulation and downregulation and metabolic hypometabolism and proliferative physiology and all kinds of things that explain this fatiguing effect that these patients have. So that is an overview of the work. So basically, what do we do for these patients? If you take them out of their bad environment or you fix their environment, they will improve by 50% usually just by doing that. And you give them a bile acid sequestrant. We use cholestyramine or Welchol as well. Cholestyramine isn't tolerated by everyone. We make Welchol water for children, put a tablet of Welchol into water and let it dissolve and give them part of that. So that's really making the treatment very basic, but that's the basic treatment. Now, there are other comorbid conditions that we see frequently because of the dysregulation, and that is we see small intestinal bacterial overgrowth, commonly SIBO. We see histamine dysregulation, coagulopathies. We test for factor VIII. We see dysregulation in that, and we also cardiolipin antibodies we check routinely. There is a bacterial colonization called Marcons in the upper nasal passage. These bacteria make exotoxins, so that we really don't like to leave them there. They just impact the hormonal regulation and production. And then we frequently see concurrently in these patients tick-borne infections, because when they get bit by a tick, their immune system is so disorganized that they can't effectively mount an appropriate defense. And so often they will have concurrent tick-borne infections as well. So I talk very fast, I'm sorry, but it's a lot. And thank you for your attention. If you have questions, this is my email, and I'm happy to talk to anyone that would like more information about this. I feel passionately that we need to start asking more questions to people when they present like this, so we can try and identify those people that might be being triggered from their environment. So I will stop my share here.
Peg, thank you so much. That was a very, very interesting presentation. Oh my gosh, it's so scary. I mean, to think, I can't even imagine. I can think of 4 or 5 buildings that I walk into on a regular basis and go, oh, that musty smell.
Yes.
So it's a little scary. But thank you for opening at least my mind to thinking about this. And we do have a couple questions in the chat. So I'm gonna, Bob, I see you're raising your hand, but let me just go to Lois first. If Lois, do you want to ask your question? And then we'll go to Bob after that. And let's see, if Lois,
yes, I am
oh, perfect.
here.
Thank you. Thank you.
Well, I had 3 of them. I just wondered if there was any kind of test pre-symptom that can be taken for people who suspect they might be vulnerable, among the 25%, in other words.
So is there some screening test that could be used? Yeah, so the easiest test to use is the visual contrast sensitivity test, which can be done online. And it doesn't mean that if you fail it, that it's not diagnostic with certainty, but it will definitely give you a hint that there is likely something impacting your ability to perceive contrast, which is an indirect measure of brain inflammation. And so at survivingmold.com, you can take the test using a computer. You do have to have good light. You have to measure the distance. So there are some controls in place, but you certainly could do that to start.
Yeah, I was thinking more of completely asymptomatic, but wondering if the genetic vulnerability is there.
So the HLA haplotypes can be easily tested. It's DRB 1, 3, 4, and 5, and DQB1, and they can be tested easily through either LabCorp or Quest. There is interpreting the results requires understanding the language of it. So it's a little like the English language, I before E except after C. So in certain of the results, but if anyone wanted to, if you wanted to have that testing done, and I'd be very happy to help you interpret the results.
Thank you very much.
You're welcome.
We have quite a few questions and maybe more questions than we have time for. So I'm just going to kind of go in order that I see them. Bob Dewey, if you'd like to go next with your question.
Peg, thank you for this lecture. This is honestly one of the scariest lectures I've ever listened to. You just think of all the patients that you've seen over the years that fit this category. It's absolutely overwhelming, really. And it just also strikes me that with all of the blood tests and then finally the gene activation, inflammation testing, that's got to get incredibly expensive. And I know that you send people for testing like this, and a lot of times it's denied. Is that a problem when you're trying to evaluate these people?
So the blood testing, if they're insured through one of the major insurers, and they don't have high deductible plans, the actual lab tests are covered quite well.
Okay.
So that's been quite straightforward. Medicare, there's a couple that they exclude, but not enough that you can't have your diagnostic criteria met. To look at the values. I'll be honest, Bob, the expensive thing about this problem and the most devastating thing that any of the clinicians that deal with this have to deal with is when you say to somebody, you could have mold in your house and it could be making you sick. The thing that they think about is the expense of fixing their house. And for some, and I have to tell you, in my primary care practice, so I have had a primary care practice for 28 years, where I have people with SIRS. I have a specialty practice, which is not insurance-based, and I see people that are already sick and have come to me because they know what I do. So those people are, and I used to have to say to my primary care people who clearly had mold problems and didn't want to hear it, don't waste this opportunity, because you could become one of my other people if you don't pay attention to this problem. It really becomes a disabling situation. But the expense of dealing with a remediation, it's significant. Yeah.
Thank you.
You're welcome.
Deborah, would you like to go next with your question?
Sure, thank you. So this is one of the things that I list when I give talks about climate change and health, is that mold could be a possible outcome of flooding. And I actually show one of the same pictures that you show from the flooding with Ian. But my question is, how do you respond to a skeptic who says, mold is all around us? There's fungus everywhere. It's on our skin. What is it about this mold that's growing inside of the buildings that's different than what we're all exposed to in the environment? Is it the quantity? Is it the particular molds? Obviously, it's susceptibility of some people, but what would you say to the skeptic about why this is a problem?
Well, definitely the burden and volume of the exposure is certainly a factor, as with any toxicity. So and that's why in talking about the tight buildings, the closed buildings, those that don't breathe, those are going to be your worst. And honestly, the contamination of central heating and cooling systems is so common that now you have diffusely present particulates throughout the building. It's not just the stacking effect from a moldy basement. So you have a susceptible person and you have a burden in the air that is at a high enough level to trigger that innate immune system. And then it just doesn't stop without removal and treatment. So, yeah.
Okay, thank you.
You're welcome.
I appreciate the talk. It's been great.
Oh, thank you.
I think we've got a couple more minutes. Robert, do you want to ask your question next?
Sure. Thanks very much. Thanks for a very interesting talk. I was wondering if you can review again why bile sequestration medications are helpful for this condition and what the evidence for that is.
Yeah, so the spores and certainly mycotoxins, but the spore burden in someone who has this condition is far greater. The spores are stored in first in the liver and then in the fat tissue when there's no room left in the liver. And so we use a positively charged binder, which is cholestyramine or Welchol, because the spores are negatively charged. So there's an attraction, there's an opposing polarity where we time the binder to be present at the circle of Oddi when the bile is excreted, and then instead of having your typical recirculation of bile, the bile attaches to the binder and then forces the liver to make new bile, and the spores are taken out with that. Now that evidence was pretty strong from the very beginning when Dr. Shoemaker had patients who had met the criteria for SIRS. They failed their visual contrast test. They had abnormal markers. They were removed from their bad environments and given cholestyramine. Their markers reversed, and they were able to pass the VCS test. So there was objective data collected in the earliest time on how the bile acid sequestration actually worked to reverse this innate immune system activation. Is that?
Okay, thank you. Thank you very much. Yeah.
Do we have time for one more question?
Yeah, definitely.
Okay, so I am going to combine Rebecca's question with my question, Peg, and wondering, Rebecca was asking, if you're concerned about this, how do you go about discussing this with your PCP? And my question was, if you're the PCP or the provider with a patient with these vague symptoms and you have this in the back of your mind, is there a screening tool that is available to screen for this? So number one, how do you initiate this with the PCP? And number two, if the PCP is suspicious of this, how would they go about screening it?
Yeah, so good questions and not easy to answer, quite honestly. And it goes back to where we really, this is ready for prime time, and we really have to educate people because, listen, I've been a busy primary care provider full-time for a long time. I know the pressures that people are under, and when people come in with something that you're not familiar with, there's not often a lot of time to be intellectually curious about that. And so what I find in the patients that I deal with, that they don't have a great success in engaging the primary cares in helping them work through this. So I'll just kind of put that out there. Occasionally, there's someone who is just incredibly helpful, and it's worth a lot. But what I would say to answer the question, what could a patient ask? They certainly could do the online visual contrast sensitivity test. And if they fail that test, then they could take that test. And I had looked at VCS testing maybe 6 years ago, collected some data on VCS testing and low MSH levels. It's very rare for someone with this condition to have a normal, above 30 alpha melanocyte stimulating hormone. They're almost always on the lower side. So I suppose a person could go with their failed VCS test and they could ask their primary care if they would order an MSH from LabCorp. We prefer LabCorp, but it could be done at Quest as well. And if that comes back on the low side, then there would be some evidence for the patient that there might be need for some follow-up, and then they, certainly visit the Surviving Mold website. The literature is all posted there. The studies are there, and they could, get some of the work that's been done and present it. It's a challenge, I have to be honest, and that's why I really thank you for this opportunity to just introduce this, because we need to do more of it everywhere.
I agree. Thank you so much, Peg. I think we've got at least one more question here, but in the interest of time, I think we'll wrap it up at this point. If your question wasn't answered, or if you have any further questions, please feel free to email those to Emily, and then she will put you in touch with Peg.